Imagine a nerve graft in an adult motorcycle victim, right? Trying to regenerate all the way from the neck, down the arm, and into the hand.
Oh, it's a nightmare. It's an anatomical marathon.
Exactly. And by the time that nerve finally reaches the finish line, the target muscle has usually died from irreversible atrophy. But in a newborn baby.
Yeah, that massive marathon is reduced to an absolute sprint.
Right. And that single fundamental difference completely rewrites the surgical rule book for brachial plexus injuries.
It really does.
Welcome, everyone. If you are a resident preparing for your plastic surgery board exams, specifically tackling the FRCS or, an equivalent high-stakes qualification, you are in the exact right place.
Absolutely.
We are dedicating this entire deep dive directly to you. There's absolutely no fluff today.
Right.
We have a very clear mission, which is to help you completely master obstetric brachial plexus palsy.
It's notoriously one of those topics that examiners just love to lean into.
Oh, they obsess over it.
They do. And to score highly, it requires you to demonstrate a really solid grasp of the underlying anatomy, a clear understanding of the clinical progression over time, and, the ability to confidently navigate some very specific, often heavily debated management pathways.
Exactly. And because we want to optimize your study time today, we're going to tackle this material strictly in a question and explanation interview style.
Keep it high yield.
Right. But before we launch into the clinical data, a quick instruction for you listening.
Yeah.
Hit that follow button right now so you do not miss any of our future revision sessions.
Please do.
Yeah.
And if you find this breakdown useful, please take a second to rate the show. It really does help us keep these focused deep dives coming for you.
For sure. Also, as a quick reminder, to access our premium deep dives, including the highly requested journal clubs and clinical cases, you will need to grab a premium subscription.
Highly recommend those.
All right, let's unpack this. To properly diagnose this injury on the ward, you first need to understand exactly how and where that delicate plexus is being damaged during delivery. What are the foundational statistics and the core mechanisms that a resident needs to be able to rattle off instantly in a Viva exam?
Okay, let's ground this in the epidemiology first. You are looking at an incidence of somewhere between 0.5 to 3 per 1,000 live births.
So fairly common in the grand scheme of things.
Yeah, and it is an injury that is noticed immediately at the very time of delivery. Now, when it comes to the primary mechanism, the etiology, this is fundamentally attributed to an increased neck-shoulder angle during parturition.
The classic stretch.
Exactly, that classic biomechanical stretching force at play as the baby navigates the birth canal.
Well, I am going to stop you right there and push back slightly because this is exactly where I see residents get tripped up in mock exams.
Oh, the traction trap.
Yes. It is so easy to default entirely to traction, that lateral stretching from the increased neck-shoulder angle, as the only mechanism of injury. But we need to emphasize the crush element here too, don't we?
That is a brilliant point and a classic pitfall you must avoid. Examiners do not want you to forget that this palsy can also be caused by severe crush injuries.
Right.
This happens specifically due to the use of instruments like forceps during a difficult delivery or as a secondary result of fractures to the clavicle and the humerus.
So it's not just stretching.
No, the trauma is not just a stretching vector. It can be direct, brutal compression of the nerves against bone.
Okay, so we have a mix of traction and direct compression. If we visualize the actual nerves, what does that physical trauma do to the architecture of the plexus?
It creates a highly mixed pathological picture. You are rarely just dealing with one clean, uniform type of nerve damage.
It's a mess in there.
A total mess. The presentation across the plexus is typically a mixture. You might have neuropraxia in one root, a partial or complete rupture in another.
And then actual root avulsion in the worst-case scenario.
Exactly.
Let's use a mechanical analogy to lock that in for the exam. A rupture or neuropraxia is essentially a postganglionic injury. It's like stretching a frayed charging cable until the internal wires snap, but the plug is still in the wall.
I like that.
And an avulsion is a preganglionic injury. The force is so great that you have literally ripped the plug entirely out of the wall socket at the spinal cord.
That wire analogy is perfect. And looking at the patterns, the most common ones heavily favor the upper roots. C5 and C6 involvement makes up 46% of cases.
Because they take the brunt of the stretch?
Precisely. Anatomically, when that neck-shoulder angle is aggressively widened, the superior roots take the absolute brunt of the tension. The next most common pattern is C5 down through C7, which accounts for 29% of cases.
Right. Okay.
And a critical detail to lock into your memory for the boards, these upper root injuries are usually postganglionic. The wire has snapped, but the plug is still in the wall.
Got it. C5C6 and C5C7 are the heavy hitters. They take the most tension, and they are postganglionic. What about the lower roots?
They are much rarer. Injuries isolated to C8 and T1, or massive panplexus injuries involving the entire network from C5 to T1, they're uncommon.
But devastating when they happen.
Devastating. When they do happen, the force required is so catastrophic that they usually feature a preganglionic element.
The plug has been ripped from the spinal cord.
Exactly.
That structural distinction, postganglionic for the common upper injuries and preganglionic for the rare lower or total injuries, that feels like a guaranteed multiple choice question.
Oh, absolutely.
Now, before we move into the delivery room dynamics, what are the non-plexus causes of a flaccid arm in a newborn that a resident absolutely must verbally rule out to show the examiner they are thinking broadly?
Excellent clinical hygiene. You cannot just have tunnel vision on the brachial plexus. You must definitively rule out a central brain injury.
Always check the brain.
Right. You must rule out local limb fractures, as we mentioned earlier regarding the clavicle and humerus. And finally, you have to consider congenital causes, things like arthrogryposis or radial synostosis, which they can mimic a paralyzed limb.
Perfect. That gives us our baseline. So we know the anatomical forces at play, but those extreme stretching and crushing forces don't just happen in a vacuum.
No, they require a perfect storm.
Right. A specific cascade of maternal, fetal, and deliver conditions. So how should a candidate structure their answer when asked about the clinical risk factors?
You should categorize them systematically into 3 pillars: mother, child, and parturition.
Nice and clean. Let's start with the mother.
A primary, highly testable risk factor is maternal diabetes mellitus, and the examiner will ask you why.
Because of the baby size?
Exactly, because maternal diabetes severely increases the risk of fetal macrosomia. Other maternal factors to list include a history of previous obstetric complications and having a multiparous pregnancy.
Okay, so maternal diabetes leads directly to our second pillar, the child. You mentioned macrosomia. For the sake of clinical precision, how large is a large baby in this specific obstetric context?
The metric the examiners want to hear is a baby that is greater than 500 grams above the average birth weight.
That's a big baby.
It is. And that immense physical bulk is what creates the critical anatomical mismatch as the child moves through the maternal pelvis. The other major fetal risk factor to note is a breech presentation, which entirely alters the traction vectors applied to the baby's neck during delivery.
Makes sense. Mother, child, and finally, the third pillar, parturition, the delivery itself.
Right. This is where the mechanical cascade peaks. The risk factors here are a prolonged second stage of labor, the necessity for instrumentation, meaning the obstetrician has to use either forceps or vacuum assistance.
Which gives us that crush element.
Exactly. And finally, the occurrence of either shoulder or head dystocia where the baby physically becomes stuck.
It really is a domino effect.
Completely. When you combine a large baby, a prolonged second stage, and the need for instruments, the physical forces exerted on that neonatal brachial plexus increase exponentially.
The maternal diabetes causes the macrosomia leads to the shoulder dystocia, the dystocia prolongs the labor, which necessitates the forceps, which causes the direct crush or the severe traction.
That's the exact narrative you need to tell. Showing the examiner that you understand how those factors interlock is how you score top marks.
Okay, so the delivery is over, and now you are doing your neonatal assessment on the ward. What specific postural signs and reflexes are you looking for?
Let's go through the distinct postural markers first. The most famous is the waiter's tip posture.
Classic.
The shoulder is internally rotated and adducted, the elbow is extended, and the wrist is flexed. If you see this, it indicates Erb's palsy, which perfectly aligns with those common C5-C6 injuries we discussed earlier.
Because the abductors and external rotators are paralyzed, right?
Exactly, so the limb just falls into that classic position. Then there is the claw hand. This indicates Klumpke's palsy involving the lower roots.
And just to interject here, because this is a nuance candidates miss, a pure claw hand or isolated Klumpke's palsy is actually incredibly rare in obstetric cases, correct?
Exactly right. It is a vital distinction to make if you want to show a consultant-level understanding.
Right.
Pure Klumpke's is incredibly rare in this specific obstetric population.
You see it more in adults.
Yeah, it is much more common in adults who fall and say, grab a branch. Moving on, if you see a baby with an isolated flexed elbow, that points to an isolated C7 injury, which is, again, very rare.
Okay.
And finally, if the infant presents with a completely flail, lifeless limb from shoulder to fingertips, you're looking at a devastating panplexus injury.
Okay, waiter's tip for herbs, claw hand for klumpkeys, flex elbow for isolated C7, and a flail limb for panplexus.
Hmm.
What about the neck? Because torticollis is almost always mentioned alongside these palsies in the literature.
Yes, torticollis frequently coexists with a plexus palsy, and the mechanism here is an associated obstetric tear, or hematoma, in the sternocleidomastoid muscle on the injured side.
So it scars down.
Right. As that muscle heals and scars, it shortens. The key clinical detail, and this is highly testable, is that the shortened muscle pulls the mastoid process down, meaning the baby's chin will usually look away from the side of the lesion.
They look away from the lesion. That is a fantastic, highly specific visual cue to remember. And what reflexes are we checking on the ward?
You must formally assess the neonatal reflexes. Specifically, you are checking the startle or Moro reflex, the palmar grasp reflex, and the asymmetric tonic neck reflex.
Now, here is a scenario that always separates the good candidates from the great ones. Let's go back to our preganglionic injuries, where the root is ripped directly from the spinal cord.
The avulsions.
Yeah. How can you clinically spot a proximal preganglionic lesion at the bedside without relying on advanced MR imaging? What are the physical exam giveaways?
You have to look for secondary markers of nerve involvement immediately adjacent to the plexus. The examiner wants to see if you know your proximal anatomy.
Right.
First, observe the baby's breathing. Are you seeing abdominal asymmetry when they inhale? If so, that indicates involvement of the phrenic nerve.
Because C3, 4, or 5 keeps the diaphragm alive.
Exactly, because a phrenic nerve originates from C3 to C5. If it's damaged, the injury is extremely close to the cord. Second, look at the back. Do you see a winging scapula?
Long thoracic nerve.
You got it.
Yeah.
That points to damage of the long thoracic nerve, which originates from the C5 to C7 roots right at the spine.
And the third giveaway.
Look at the face and eyes for Horner's syndrome, a drooping eyelid and a constricted pupil. If you see Horner's, you know the damage is devastatingly proximal.
Because of the sympathetic chain.
Right, because the sympathetic chain sits directly adjacent to that T1 root level. Finding any of these three abdominal asymmetry, winging scapula, or Horner's points strongly toward a severe preganglionic root avulsion.
That is incredibly high yield. Phrenic, long thoracic, and Horner's give away the avulsion. So you've completed that detailed physical examination. Now, a resident must be able to formalize those clinical findings into a universally accepted prognostic system.
The Neurocus classification.
Exactly.
Anyway.
You can't just ask a newborn to squeeze your finger to grade their strength. Can you walk us through the 4 groups of the Neurocus classification and, crucially, the spontaneous recovery rates associated with each?
Absolutely. The Neurocus classification is the absolute gold standard here. It was designed specifically because we cannot do complex motor testing on infants. Let's build it step by step.
Okay, group 1.
Group 1 involves C5 and C6. Clinically, as we noted with Erb's palsy, this presents as paralysis of the shoulder and elbow flexion. The prognosis here is excellent, with a greater than 80% chance of spontaneous recovery without surgery.
Group 1, C5, C6, shoulder and elbow, over 80% recovery, moving down the plexus.
Group 2 adds the next group. So Group 2 is C5 through C7. The clinical presentation on the crib is exactly the same as Group 1 paralysis of the shoulder and elbow flexion, but with the addition of a wrist drop.
The wrist drop.
Right. Because we have more root involvement, the spontaneous recovery rate drops slightly, but it is still good at greater than 60%.
Okay, group 2. C5, C7, add the wrist drop, over 60% recovery. What happens when the whole plexus is involved?
That brings us to Group 3. This C5 right down through T1. The clinical picture is complete flaccid paralysis of the entire limb.
Ouch.
Yeah. The spontaneous recovery rate here plummets to between 30 and 50%. But here's the crucial, somewhat paradoxical detail for your exams. Even with complete flaccid paralysis initially, many patients in Group 3 will still eventually have a functional hand.
Wait, I want to highlight that because it feels counterintuitive. Complete flaccid paralysis from C5 to T1, but they might still retain a functional hand down the line. Why is that?
It comes back to the biomechanics of the injury. The upper roots C5 and C6 almost always take the most severe permanent stretch and avulsion damage.
Right.
The lower roots C8 and T1 might initially be shocked into a state of neuropraxia due to the surrounding swelling and trauma, causing total flaccid paralysis on day 1.
But they're not ripped.
Exactly. Because those lower roots weren't physically ripped apart, they eventually wake up, giving the child hand function back.
That structural nuance is exactly what an examiner wants to hear. And the final Naracus group.
Group 4. This is C5 through T1 complete flaccid paralysis, plus the presence of Horner's syndrome. As we discussed, Horner's means the T1 root is likely avulsed from the spinal cord.
Which means no hand function is coming back.
Right. This combination carries the absolute worst prognosis of all the groups.
Group 4 is the worst-case scenario, complete flaccid paralysis plus Horner's. Knowing the Naracus classification directly dictates the urgency of your intervention, which brings us to the most notoriously debated area in plastic surgery, management pathways.
Oh, it's a minefield.
It really is. There is a wide range of acceptable practice globally. But to pass the exam safely, what are the absolute indications for surgery, and what investigations are actually worth ordering?
You are right, it is a controversial topic, but there is firm, agreed-upon ground. The absolute surgical indications that almost all surgeons agree upon are presentation of Naracus Group 4 or any confirmed T1 root avulsion.
That makes sense.
If you have either of those devastating proximal injuries, early surgery is indicated. For almost everyone else in the other groups, the initial management is strictly non-operative.
And what does that non-operative management actually look like day-to-day for the parents and the child?
It centers entirely around dedicated daily passive exercises. The goal is simple but vital, to maintain the full, supple range of motion in those shoulder and elbow joints, preventing contractures until the plexus hopefully recovers on its own.
And to track the structural side of that recovery, what imaging or tests are we using?
You use ultrasound specifically to assess diaphragm function if you suspect phrenic nerve involvement. And you use CT myelography or a high-resolution MRI to clearly show if there are root avulsions at the spinal level.
Now, here's where I want to interject with a massive trap that catches people out on exams regarding tests. What about electrophysiological tests? We use EMGs and nerve conduction studies all the time to map adult nerve injuries. Why aren't we discussing them here?
And that is exactly why it is a trap. Electrophysiological tests are distinctly less usable in obstetric palsy compared to adult brachial plexus injuries.
Why is that?
The infant nervous system is immature, the anatomical distances are tiny, and trying to get reliable, artifact-free baseline data from an awake, crying infant is incredibly difficult. You get a lot of false positives and negatives.
So just don't base your exam answer around it.
Do not make the mistake of relying heavily on electrophysiology in your exam answers for this specific neonatal population. Clinical examination is king.
Excellent point. Stick to the clinical exam. So if we are relying heavily on clinical exams over time, what are the specific timeline milestones we need to memorize? When do we officially abandon passive exercises and pull the trigger on surgery if things aren't improving?
Repeated, standardized examination is your best tool. Here are the 2 critical timelines you need to anchor in your mind.
Okay.
First, if you see partial recovery, which is defined clinically as at least an MRC grade of M3 within the first 2 months of life, that usually indicates the child will go on to make a full recovery by age 2.
Just to clarify for the listener, an MRC grade of M3 in a baby means they can actively move that joint against gravity. So M3 at 2 months means full recovery by 2 years.
Precisely. On the other end of the spectrum, if some active biceps and shoulder function has not recovered by 6 months of age, that is the universally recognized milestone where most surgeons will definitively recommend surgical reconstruction.
Nothing against gravity by 6 months equals reconstruction. That is a very clear, defensible decision tree. Which brings us to our final area of focus.
The protocol.
Right. When the clinical picture remains borderline after those initial few months, surgeons rely on specific, validated protocols to make the final call on whether to operate. Tell us about the famous Hospital for Sick Kids protocol out of Toronto, and then let's get into how the surgical principles for babies differ so drastically from adults.
The Hospital for Sick Kids in Toronto developed a highly regarded, validated test score to guide early treatment decisions. Their protocol works like this. If the infant makes satisfactory early improvement according to their proprietary test score, surgery is completely postponed for 9 months to allow for maximum spontaneous regeneration.
They wait almost a full year based on that early score. And what happens at that crucial 9-month mark?
At 9 months, they perform what is known as the cookie test. It is a wonderfully simple but profoundly revealing clinical test.
I love this test.
It's great. You place a cookie in the child's hand. Then, while you securely hold the child's humerus tight against their side, you observe if the child can bring that cookie to their mouth strictly by flexing their elbow.
I want to break down the mechanics of that test. Holding the humerus against the chest wall is the absolute key to it, right?
Oh, without a doubt.
Because otherwise, a baby with a paralyzed bicep will use a trick movement. They will abduct their shoulder to use gravity to swing their hand up to their mouth. By pinning the humerus, you eliminate that cheat and force them to isolate the elbow flexion.
Exactly. You are isolating the true recovery of the musculocutaneous nerve. And the outcome is binary. An inability to reach the mouth with the cookie under those strict conditions is a clear, undeniable indication for surgery.
Let's talk about the surgery itself.
Yeah.
Let's say the cookie test has failed and we are scrubbing into the operating room. How do the surgical principles here differ from what a resident would do for an adult motorcycle accident victim?
There are three major paradigm shifts you must articulate to the examiner. First, in obstetric palsy, reinnervating the hand is prioritized over the shoulder.
Okay, hand over shoulder.
Second, neurolysis, the act of simply freeing up the scar tissue around an intact nerve, is notably not as effective for obstetric palsy as it might be in other adult scenarios. You usually need to resect the neuroma and graft.
Skip the neurolysis, go straight to graft.
Usually, yes. And third, unlike in adult injuries, long nerve grafting and nerve transfers can actually successfully reinnervate the hand.
And this is where we come back to that analogy from the very beginning, because it completely dictates the surgical strategy.
Yeah.
Nerve regeneration is basically a race against time before the motor end plates in the muscle die.
Right.
In an adult, a nerve graft trying to grow from the neck down to the intrinsic muscles of the hand has a massive anatomical racetrack to cover, and it simply runs out of time. The muscle dies before the nerve arrives. But in a baby, that anatomical racetrack is drastically shorter.
That is the exact physiological reality. The distances are so short that the regenerating axons can actually reach the motor end plates of the hand before irreversible atrophy sets in.
It's a sprint, not a marathon.
Exactly. That shorter regrowth distance makes hand reinnervation a viable, achievable goal, which is why we aggressively prioritize it in infants, whereas we might just abandon it in adults.
And with that, we have covered the complete arc of obstetric brachial plexus palsy. We went from the 0.5 to 3 per 1,000 incidents and the crushing biomechanical forces of the delivery room, all the way through the anatomy of Horner's syndrome, the 4 specific groups of the NERACA's classification, and finally, the surgical logic behind the 9-month cookie test.
We really covered a lot of ground.
We did.
Yeah.
I want to congratulate you for powering through this. This was a dense, highly technical revision session, but you are now armed with the exact data points, anatomical reasoning, and clinical frameworks the FRCS examiners are looking for.
You have the framework. Now it is about application. And to leave you with a final thought to mull over independently before your next shift, consider how the rapid exponential physical growth of an infant's long bones during that critical first year might fundamentally alter the microenvironment and the mechanical tension of a healing nerve graft compared to the static, unchanging anatomy of an adult patient.
Oh, a brilliant concept to leave you with. Please leave a comment or a question about today's material in the show's notes or the discussion section. Keep studying hard, trust your preparation, and we will see you on the next deep dive.